So this is chapter 9, in which we are going to talk about joints. So we'll start with a brief introduction. So a joint is also called an articulation, and this is a spot where two bones interconnect. So anytime two bones connect, whether it can be a movable area or not, it's still called a joint or an articulation. There is a compromise between strength and mobility when it comes to joints, and what we mean by this is that very strong joints have very little, if any, mobility, meaning that they're strong but they don't move, versus joints that have a lot of mobility are relatively weak. So you can't have the best of both worlds. You can either have a lot of mobility or you can have strength, but you can't have both. There are two ways to categorize joints, and we're going to introduce them here and then go into more detail on following sections. So you can categorize joints based on their function, and this is based on their range of motion, so how movable they are. So you have synarthroses, which are immovable joints, amphiarthroses, which are slightly movable, and then diarthroses, which are freely movable. And we're going to go into detail about each of those in the upcoming section. We can also classify joints based on their structural classification, which is based on the anatomy of the tissue that is joining one bone to another. So there are 4 different types of classifications here. You can have bony, fibrous, cartilaginous, or synovial. So there are combinations of these two types of categorization. So for example, an amphiarthrosis could be either fibrous or cartilaginous. So we're going to go into that level of detail in the next section. In this section, we'll look in a little more detail at the different classifications of joints. So first, we'll start with the 3 broad categories. These are synarthroses, or immovable joints, and these can be either bony, fibrous, or cartilaginous. Amphiarthroses are slightly movable joints, and these can be fibrous or cartilaginous. And then there is a diarthrosis, which is a freely movable joint, and these are also called synovial joints. Diarthroses have 3 different planes of movement. So if you look at the bottom right corner, if you imagine movement in the 3 dimensions, a monaxial joint will allow movement in one plane. So in this image, it would be like along the axis of the green arrows. A biaxial joint will allow movement in 2 planes, so like the green arrows and the blue arrows. And a triaxial joint will allow movement in all 3 planes, so the green, the blue, and the red arrows. So now let's look at these in a little bit more detail, starting with the synarthrosis. So the synarthroses are extremely strong joints, but they don't allow any movement. Remember earlier we said that there's a trade-off between strength and mobility. So the stronger the joint, the less the movement that you have, and vice versa. The more movement you have, the relatively weaker the joint. So there are 3 subcategories of synarthroses. There's 4 subcategories. The first one is a suture, and we already talked about these in chapter 7 when we looked at the cranial bones. So a suture is a type of fibrous joint, and with a suture you have bones that interlock with each other and connected by dense fibrous connective tissue, and you only find sutures in the bones of the skull. And you had to learn the name of 4 of the major cranial sutures back in chapter 7. Another type of synarthrosis is a gomphosis. This is also a fibrous type joint. This is where the teeth are connected to either the maxilla or the mandible. Remember, the maxilla is your upper jaw, the mandible is your lower jaw, and the teeth are connected to these bones by the periodontal ligament, which again is a type of fibrous connective tissue. The third type of synarthrosis is a synchondrosis, and this is a cartilaginous type joint. Notice that the chondro root word that means cartilage is in the name. In this type of joint, you have a cartilage bridge between 2 bones. And the best example of this one is like the hyaline cartilage that you have in your thoracic cage between the ribs and the sternum. Remember, we called these costal cartilages. This type of joint is called a synchondrosis. And the fourth type of synarthrosis is a synostosis. This is a bony type joint, and this is when you actually get full fusion between two bones. So the two bones fuse so tightly together that it's now just one large bone. An example of this would be the epiphyseal line that you get after development when the epiphyseal cartilage plate closes when growth stops. And also, when we looked at the fetal skull in Chapter 7, you saw that during fetal development, there is a frontal suture in the frontal bone, but as you grow, that suture completely fuses, and that's what we call a synostosis, and that's what's shown here in this little image. So these are the four types of synarthroses. These are all very strong joints, but they do not allow any movement. The next type of joint is an amphiarthrosis. Remember, these are slightly movable joints. So they allow more movement than a synarthrosis, but they are stronger than a diarthrosis, which is the freely moving joints. So these joints are like right in the middle, medium strength and medium movement. So there are two types of amphiarthroses. The first type is a syndesmosis, and this is a fibrous type joint. In a syndesmosis, bones are connected by a fibrous ligament, and we saw this in Chapter 8 with the interosseous membrane that is between the tibia and the fibula, as well as the ulna and the radius. So that is a syndesmosis. The other type of amphiarthrosis is a symphysis, and this is a cartilaginous type joint. And with a symphysis, you have two bones that are separated by a wedge or a pad of fibrocartilage, like the piece of cartilage that is between the two pubis bones of the hip. And remember, we called this the pubic symphysis back in Chapter 8. So those are the two types of amphiarthroses, syndesmosis and a symphysis. And again, these allow more movement than the synarthrosis, but they're stronger than the diarthrosis. And finally, we have the diarthrosis. These are your freely movable joints. These are also called synovial joints. They permit a wide range of motion. We already talked about the monaxial, biaxial, and triaxial, so movement in one axis, two axes, or three axes. And we're going to spend a lot more time on diarthroses in upcoming sections, so we're just introducing you to this type of joint here. In this section, we're going to look at the synovial joint structure. And again, remember that these are diarthroses. So if we look at a typical synovial joint, which is shown in this image in the upper right, the first structure we're going to look at is the joint capsule. So all synovial joints are surrounded by this joint capsule. It starts where the periosteum that covers the bone ends. So you can see the periosteum here in a beige color, and the joint capsule itself is shown in this light blue color. The joint capsule has two layers. There is an inner synovial membrane, which is shown as pink in this image. And we talked about synovial membranes back in Chapter 4 when we introduced you to tissue membranes. If you recall, a synovial membrane was composed of a layer of areolar tissue covered by an incomplete epithelium. The cells in the areolar tissue produce synovial fluid, which fills the inner joint cavity, and we will talk more about synovial fluid on the next slide. The outer part of the joint capsule is an outer fibrous capsule, and that is the part that is shown as light blue in this image. So the bony ends of the joints at synovial joints are covered by articular cartilage, which is made of hyaline cartilage. And when we talked about bone development in Chapter 6, if you remember, when the endochondral ossification was occurring and the cartilage was being replaced by spongy bone and compact bone, there was this small little piece of cartilage that was pushed up to the ends of the bone, and that is what becomes the articular cartilage. So it is made of hyaline cartilage, but it does not have a perichondrium because it is open to the inside of this joint cavity, and as you'll see on the next slides, its synovial fluid needs to be able to go into and out of the cartilage matrix. The matrix also contains more water here than it does in other places, so this is like a more watery form of hyaline cartilage. The articular cartilage surfaces are very slick and smooth, and they serve to minimize friction within a joint. So when these two bones have pressure put on them and they press up against each other, this is to minimize the friction of those two bones rubbing together. If you do damage your articular cartilage, that smooth surface goes away and it can become an abrasive surface because all of these little collagen fibers are broken and sticking out, and that can actually increase friction and cause a lot of pain at a joint. And this can happen with age and with injuries to joints, like during activities. So we mentioned the synovial fluid that was made by the cells of the areolar tissue in the synovial membrane. So let's talk in more detail about the synovial fluid. So it is very similar to interstitial fluid, but it does have a higher density of proteoglycans to give it more of like a syrupy consistency. The synovial fluid in here, think of the cartilage at the ends of the bone, the articular cartilage, think of them as kind of acting like sponges. So when you press them down, so like when the two bones press against each other, the synovial fluid will be squeezed out of the cartilage and into the space around it. And then when you're resting or not putting any weight on a joint or any stresses on a joint, then the synovial fluid will be sucked back up into the cartilage. So the synovial fluid is constantly being soaked up and wringed out of the articular cartilages. So synovial fluid has three main functions. First, it helps with the lubrication, so it helps with the reducing friction between these two bony surfaces. It also provides nutrient distribution for the chondrocytes in the hyaline cartilage. Remember, cartilage is avascular, so it doesn't have a blood supply. So the chondrocytes have to get their nutrients and waste disposal taken care of by the synovial fluid. So the more active you are and the more you are using your joints, the more that fluid's going to be soaked up and wrung out of the cartilages, and the healthier the cartilages will stay. And this is one reason why activity is encouraged over a sedentary lifestyle, because if you stayed on the couch all day long, you're not helping your cartilage to get that fluid soaked up and wrung out repeatedly as if you were actively using a joint. The synovial fluid also helps with shock absorption, so it cushions shocks and sudden impacts. So for example, think of your knee joint when you're running. So when you land on your leg and all of your body weight comes down on your knee, the increased pressure that's put on that joint actually causes the viscosity or the thickness of the synovial fluid to increase, and that cushions that shock and keeps less of that shock from affecting the bones. So synovial joints also have accessory structures. So first we'll look at cartilage and fat pads. So cartilage pads are pads of fibrocartilage that can be found inside joints. These are called menisci. So menisci is plural, a meniscus is singular. An example is the menisci you can find in your knee joints. And in this image over here of a knee joint, you can see the meniscus is this pad of fibrocartilage right here in the middle. So it's between the two articulating surfaces of bones. The cartilage pads can help to subdivide a joint cavity. It can also help to channel the flow of the synovial fluid, and it can allow for shape variations in the articular surfaces of the two bones. You can also find fat pads associated with synovial joints, and these are little sections of adipose tissue covered by a synovial membrane. And we can see a fat pad in this image as well. These help to provide protection for the articular cartilages, and they serve as packing material to fill spaces within joint cavities. And then as you move and the shape of the joint cavity changes, they can also move along with that to help fill the spaces in that are created by the movement. Next, we'll look at the accessory structures that are ligaments and tendons. Just a quick reminder, this was covered in Chapter 4. A ligament is a connection between one bone and another bone, and a tendon is a connection between a muscle and a bone. So you can find a lot of ligaments around synovial joints. There are two types. An extracapsular ligament is located outside of the joint capsule. So again, if we look at our sample knee joint structure here, the extracapsular ligament would be this one right here because it is outside of the joint capsule. You also have intracapsular ligaments, this is a mouthful, which you find inside the joint capsules. And an example would be the cruciate ligament of the knee, which is located in here close to where the meniscus is. A sprain is when you have a ligament that is stretched enough to tear the collagen fibers that make up that ligament. And as long as it's just a few of the fibers that are torn, then the ligament as a whole survives and the joint itself isn't damaged. But if you actually tear the entire ligament, so not just a few fibers, but the entire ligament, that is a really bad condition because ligaments have no direct blood supply and they don't heal very well, and that will usually require a surgery. Usually ligaments are so strongly attached to bones that a bone is more likely to break before a ligament would tear completely, and that is not such a bad thing because, as we covered in Chapter 6, bones heal very well. So bones heal a lot more easily than ligaments do. So tendons are also considered an accessory structure, although they usually are not inside the joint capsule itself. They are surrounding the synovial joint, but they do play a role in helping to stabilize synovial joints. So by passing nearby, they can help limit the range of motion of the joints and provide mechanical support. So for example, there's a lot of tendons that surround your shoulder joint to help brace it. It's actually called the rotator cuff, and we'll talk about that a little bit later. Continuing with accessory structures, next we have bursae. So again, bursae is plural, bursa is singular. So a bursa is a small fluid-filled pocket. This is a small pocket of synovial fluid that is lined by a synovial membrane, and it's shown here in this image by these little flat green areas. So that's a bursa. These are some more bursae down here. So these form where tendons and ligaments rub up against other tissues. So they form in a place that's you need a little bit of extra padding, and they actually do help reduce friction in those areas, and they also help with shock absorption. Now, if you overuse a particular joint, and so you're overusing that particular area, and the tendon and the ligaments are rubbing over and over and over a particular place, your bursa can become inflamed. So bursitis is the inflammation of the bursae. And this can happen to people with repetitive motions of certain joints, like a shoulder joint with a golfer, for example. And so it becomes very painful and swollen, and the bursa itself can become swollen with extra synovial fluid. And a special type of bursitis is called a bunion. A bunion is pressure-related bursitis, and this usually occurs at the base of the hallux, which is your big toe, from wearing high heels or pointy-toed shoes, and it comes from putting extra pressure on that big joint at the base of your big toe. And the last slide in this section is we'll talk about the stabilization of synovial joints. So remember, synovial joints are freely movable joints. And as we mentioned before, if you have increased mobility, that means you have decreased strength. So the synovial joints do have a lot of mobility, so they're not going to be as strong as a suture. So they need a lot of help to stabilize their position and to keep that particular joint from moving outside of the normal range of movement that it should be limited to. So factors that work to stabilize joints, you do have the collagen fibers in the joint capsules, which can help to provide stability. You have those accessory ligaments. Remember, they can be inside or outside the joint capsule. The shapes of the articulating bones and the cartilage pads called menisci can again further help stabilize that joint. The presence of other bones, skeletal muscles, or fat pads can, again, think about these are ways to keep the joint from moving out of position or moving too far in one direction or another. Also, the tension and tendons that are attached to the bones that are articulating at that joint. And then a couple of terms to know. If all of these factors up here don't work, and a synovial joint is stressed to the point that the articulating surfaces are forced out of position and you have a complete loss of contact between those two bones that were forming that joint, that is called a dislocation. And if you have a partial loss of contact, that is a subluxation. So a subluxation is a partial dislocation. So when we're talking about all of these ways to stabilize synovial joints, we are basically saying that these are all ways to try to prevent dislocations from happening, but they still can happen, and we'll talk a little bit more about some of those later on. In this section, we're going to go over the movements at synovial joints. So we're going to start with flexion and extension, and let me point out that all of these movements, the starting point is the anatomical position. So this is why we taught this to you in chapter 1. So go back and review what your anatomical position is. So with flexion and extension, movement is in the anterior and posterior plane, and I have some videos I will show you in a moment. But flexion is going to be decreasing the angle of a joint. So if we look at the head as an example, if you move the head forward, so you're moving it in the anterior direction, you are decreasing that joint at the neck, and that is called flexion. Going back to the anatomical position by increasing the angle is extension. And note that when you're in the anatomical position, all of your joints are in the extended position except for the ankle. The ankle is flexed in the anatomical position. Everything else is extended. If you go past the anatomical position and continue back into the posterior plane, that is called hyperextension. So hyperextension is moving past the anatomical position. So this will be clear with some videos. So let's take a look at some videos at some of the common joints that can do flexion and extension. Again, remember the starting point for all of these movements is the anatomical position. So let's take a look at the neck first. So moving forward in the anterior plane would be flexion. Moving back to the anatomical position would be extension. And then moving farther into the posterior plane would be hyperextension. So one more time, flexion, extension, hyperextension. We can also look at the shoulder. So we're looking at the joint between the humerus and the scapula. So with the shoulder, if we move it forward in the anterior position, that's flexion. Moving it back to the anatomical position is extension. Moving it past the anatomical position, further posterior, would be hyperextension. So seeing those again, flexion, extension, hyperextension. The elbow can flex and extend, but because of the structure of the elbow, it cannot hyperextend, and we'll see why when we get to the section on the elbow. So with the elbow, you can have extension. You can have flexion, and then you can have extension. So with the elbow, you just have flexion and then extension. With the hip, so we're talking about the joint between the hip bone and the femur, you can have flexion, which is again moving into the anterior plane. You can have extension back to anatomical position, and you can hyperextend by going further posterior. So again, at the hip, flexion, extension, hyperextension. The knee is like the elbow. Because of the structure of the joint, you can only have flexion and extension. You cannot have hyperextension. And the knee is one of the exceptions in that the movement is actually going to be in the posterior plane. So with the knee, you have flexion when you bend the knee and decrease that joint. And because of the structure of the knee, this is the one that is actually going to go back into the posterior position when it's flexed. So that's knee flexion, and then going back to anatomical position would be knee extension. You can also flex and extend your spine. So bend forward, that would be flexion. You straighten back up to anatomical position would be extension. Hyperextension is if you go farther posterior. You can also flex and extend and hyperextend your wrist. So again, if we move our wrist into the anterior position, that's flexion. Back to anatomical position would be extension, and you can hyperextend your wrist by going farther posterior. So flexion, extension, hyperextension. You can also flex, extend your fingers. So with your fingers, if you curl them inward, that is flexion. And then if you bring them back out to anatomical position, that's extension. So with the fingers, you have flexion and you have extension. The next type of movement we'll look at is abduction and adduction. So in abduction and adduction, we are moving around the longitudinal axis of the body. So if you imagine the frontal plane, so remember the coronal or frontal plane that separates the anterior half of the body from the posterior half. So if we're moving in that plane, that is called abduction and adduction. So with abduction, you are moving away from the main axis of the body. And a way to remember this is think like when aliens abduct people, they take them away. So abduction is taking the limb away from the main axis. And then adduction is adding it back. So abduction, we're abducting it and taking it away. Adduction, we are adding it back to the main axis. You can also abduct and adduct your fingers. Although in this case, instead of the main axis of the body, imagine a line going down the center of your hand. Abduction of the fingers are spreading them and taking them away from that center line, and adduction would be bringing them back together toward that center line. And notice that the abduction and adduction movements are only applicable to the appendicular skeleton, so to your arms and legs and fingers. So if we take a look at a couple of videos for this one, again, remember the starting position is the anatomical position. So also remember that these movements, abduction and adduction, only apply to your appendages. So we'll start with the shoulder. So if we move the shoulder so that the arms move away from the body, that is abduction. And if we move the shoulder so that the arms come back, that is adduction. So again, moving away from the midline is abduction. Moving back toward the midline is adduction. So ab is away, add is back. Ab, add. All right, so abduction is away, adduction is bringing it back. You can also have this motion at the hips. So abduction would be moving the hip away from the midline of the body. And again, we're in the frontal plane, so we're moving side to side. We're not actually moving anterior or posterior. Adduction of the hip would be bringing it back. Abduction would be taking it away. Adduction would be bringing it back. All right, so that's abduction, adduction. You can also abduct and adduct your wrist. So if you bring your wrist closer into the body, that is adduction. I'm adding it closer to the body. If I take the wrist farther away, that is abduction. I'm taking it away. So that is abduction of the wrist, and that is so adduction of the wrist, abduction of the wrist. Remember, add is going toward, ab is going away. And then with the fingers, we are treating the midline as being an imaginary line down the center of the hand. So this would be abduction, taking the fingers farther away. And then adduction would be bringing them back. So adduction is adding them back to the midline. Abduction is taking them away. So one more time. Abduction, adduction. Abduction, adduction. There's also a type of movement called circumduction. This is movement in a circle without rotating a bone. So you can imagine if you had a piece of chalk in your hand and you're trying to draw a big circle on a chalkboard, your shoulder joint is moving in a motion called circumduction in order to do that. So we have in 2 videos, so your shoulder and your hip joint are 2 of the joints that do circumduction, and it was a little hard for me to get my video to do this very clearly, but to give you an idea, the shoulder joint, moving it in a big circle, right, coming back to starting point, that is circumduction. And the hip, you could do a big circle if your other leg wasn't in the way, but if you imagine just, trying to move your hip in a circle as much as you can, that is also circumduction. And the thumb can also circumduct, but I wasn't even going to try to get my little guy to circumduct his thumb. So the 3 joints you can circumduct: shoulder, hip, and thumb. So now we'll look at rotation. So in the limbs, your arms and your legs, you can have medial or lateral rotation. So medial rotation is rotating the limb toward the midline of the body. It can also be called internal rotation. And lateral rotation is turning the limb or rotating it away from the midline of the body, and that is also called external rotation. And then with the head, you can have left and right rotation, and this is going to be that joint between the axis and atlas that we talked about back in chapter 7. So to show you what this looks like, so we'll start with lateral medial rotation. So if we look at the shoulder, so notice that I am actually, so the elbow joint does not participate, and neither does the wrist. So this is just at the shoulder. So if I rotate my shoulder so that my arm twists in toward my body, that is medial rotation. And if I rotate my shoulder so that my arm twists away from the body, that is lateral rotation. All right, so once again, medial rotation, lateral rotation. You can also do this at the hip. Medial rotation, rotating inward toward the midline of the body. Lateral rotation, rotating away. So again, this is happening at the hip, not the knee or the ankle. So that was the hip joint. And then left and right rotation with the head. This is because of the atlas and axis and that little dens that sticks up from the axis, and the atlas rotates around it. So you have left rotation and right rotation. So some special cases of joint movements. So we'll start with a special case of rotation. So the proximal radial head can actually rotate. So the radial head, remember, looks like a nail, and it fits up against the capitulum of the humerus. So you can get rotation there. And then there's also some joints in the wrist that allow this. And so this allows you to rotate your forearm. And so when you rotate your forearm so that your palm faces backwards, that is called pronation. And when you rotate your forearm so that your palm is facing forward, that is called supination. So when you're in the anatomical position, your forearm is in the supinated position. So let me show you the video, right? So again, this is happening at the wrist and the elbow. So in the anatomical position, this is supination. If I rotate my forearm so the palm faces backwards, that is pronation. Then if I bring it back, that is supination. So pronation, supination. One more time. Pronation, supination, pronation, supination. Some other special movements. So at the ankle, and this is actually between the talus and the calcaneus that allows for this movement, you can turn the sole of your foot inward, and that is called inversion. You can also turn your sole slightly outward, and that is called eversion. And at your ankle, you can also, there's actually special terminology that we use at the ankle. So the ankle can flex and extend like we talked about before. So remember, flexion is moving it forward and reducing that joint. Extension is moving it farther away and making that joint greater. But we have special names for this. So when we flex the ankle, we actually call it dorsiflexion. And when we extend the ankle, we call it plantar flexion. A plantar is another name for this, like the sole of the foot down here, and so when you extend the ankle, it bends the plantar region, and that's why it's called plantar flexion. It's confusing, I know. Blame the early anatomists. So if we take a look at this, so let's look at inversion and eversion first. And my little guy can do a little bit more extreme than we can, but you can try with your own foot to see how far you can go. Inversion would be turning the sole inward, and eversion would be turning the sole outward. So most people can only evert very slightly. All right, so inversion, turning the sole inward, eversion, turning the sole outward. And then dorsiflexion is the same thing as flexion. So that would be ankle flexion, also called dorsiflexion. And then if you point your toe, that is ankle extension, and it's also called plantar flexion. So again, this one you just have a couple of different names to know. Ankle flexion, dorsiflexion, ankle extension, plantar flexion. All right, some other movements. So your thumb has a special saddle joint that we'll talk about in a bit. And so with the thumb, you can have a movement called opposition, which is bringing it forward. The same movement that you would use if you were going to like touch your pinky finger with your thumb, and then bringing it back to the original position would be called reposition. And then your mandible, so your lower jawbone, remember it forms a joint with your temporal bone. So with your mandible, if you move your lower jaw in the forward direction, that is called protraction. If you move your jaw in the backward direction, that is called retraction. So taking a look on the left, we're going to look at opposition and reposition. So moving my thumb forward like this is opposition, and then putting it back would be reposition. So opposition, reposition. And then with the mandible or jaw, this would be protraction, retraction. So it's very slight, but you see how it can move forward and then back. So protraction, retraction. Your jaw can also elevate and depress, and so can your shoulders. So elevation is a superior movement, or moving the joint in a superior direction. Depression is an inferior movement, or moving downwards. And then the final special movement is called lateral flexion. And this is your vertebral column can do this. So the different areas of your spine, cervical, thoracic, and lumbar. And this is bending of the vertebral column from side to side. That is called lateral flexion. So on the left, we have elevation and depression. And so first I'm going to show you using the mandible or your lower jaw. So depression would be like when you open your mouth, so your jaw lowers, that is depression. Elevation is when you raise it up to reclose your mouth. So you'll use this a lot when you talk or eat. So depression and elevation. You can also have depression and elevation with your shoulders. So this is actually movement at the scapula. And so your scapula can elevate and depress. So when you shrug your shoulders, your scapula is elevating. And when you unshrug them, it's depressing. So elevation of the scapula, depression of the scapula. And then with lateral flexion, I'll show you first in the cervical area, so your neck region. Lateral flexion would be bending your head left and right like this. But you can also have lateral flexion in the lower areas of your vertebral column. If you were to bend your whole body to the left or the right like this, that is lateral flexion using your thoracic and lumbar spine. In this section, we're going to look at the 6 different types of synovial joints. So we're going to start with the plane joint, which is also called a gliding joint. So with this type of joint, you've got flat articular surfaces that basically just slide across each other, so very slight movements. They technically could rotate, but ligaments typically surround them and prevent rotation. So here is a little GIF to show you. One example of a gliding joint is between the articular processes of your vertebrae. So between the inferior articular process of one vertebra and the superior articular process of the one underneath it. And so you have very slight movement between these joints, and that is what we call a gliding joint or a plane joint. So you can find these between the scapula and the clavicle, that's that acromioclavicular joint. Also between the clavicle and sternum, that's the claviculosternal joint. You can also find them between your different carpals. Remember, you have 8 different carpal bones, so the intercarpal joints are gliding joints. The intertarsal joints are also gliding joints, so this is between your 7 tarsals. You also have these between your ribs and your thoracic vertebra, and those are called vertebrocostal joints, so between a vertebrae and a rib. You also have them, as I mentioned over here, between one vertebrae and the one above it and below it. This is the type of joint that is between those articular processes. And then you also have a gliding joint between the sacrum and the ilium, and that is the sacroiliac joint. So notice that both joints that connect the appendicular skeleton to the axial skeleton, so the joints of both girdles, your pectoral girdle and your pelvic girdle, are both gliding or plane joints. The next type of joint is a hinge joint, and this works a lot like a hinge on a door. So it permits angular movement in a single plane. So if we look at a video, a hinge joint just allows this one type of movement in one plane of motion, and hinge joints allow joints to flex and extend, and that's all. So you have hinge joints in your elbow between the humerus and the ulna. Also your knee joint between the femur and the tibia. A hinge joint is also in your ankle between the tibia and the talus. And then in between your phalanges, so your interphalangeal joints. So for example, between a proximal phalanx and a middle phalanx, or between a middle phalanx and a distal phalanx. So just to remind you, your phalanges, so these are your fingers and your toes. Remember, we had proximal phalanx, middle phalanx, and a distal phalanx. And so you were able to flex and extend both of these finger joints and toe joints, and those are all hinge joints because you were only able to flex and extend. The next type of joint is a pivot joint. A pivot joint allows only rotation, so the rotation of something around something else. So if we look at this image here, so a pivot joint is going to be one bone rotating around or within another bone. And here's another example, because your radius can pivot or rotate around the ulna to allow you to supinate and pronate your forearm. And go back and look at the synovial movements to remind yourself the difference between supination and pronation. So you have pivot joints between the atlas and axis, so your first and second cervical vertebrae. This is called the atlantoaxial joint. So this allows you to rotate your head, so left and right rotation, so as if you were shaking your head no. And then you also have a pivot joint between the radius and ulna at both ends. The head of the radius fits into the radial notch at the proximal end, and then you also have a pivot joint down here at the distal end, and that allows for the supination and pronation movement. The next type of joint is a condylar joint, which is also referred to as an ellipsoid joint. So in this type of joint, we are allowing angular movement in 2 directions, but because the bones that connect together are more oval shaped than ball shaped, we cannot get any rotation. So if we take a picture here, so the 2 directions, so you can get flexion and extension, that's in one direction, that's like your anterior posterior direction. And then you can also have abduction and adduction, which is in the other plane of movement. And then because you can move in all 4 directions, you can also do a circle, which is called circumduction. The only thing you cannot do here, no rotation. So you can flex, extend, abduct, adduct, and circumduct. So you have condylar or ellipsoid joints between your radius and your carpal. So this is your wrist. So this is the radiocarpal joint. This is why you can flex your wrist, extend your wrist, abduct and adduct your wrist, and you can move your wrist in a circle so you can circumduct your wrist as well. It's also between your metacarpals and your proximal phalanges. So the joint is called a metacarpophalangeal joint. So this is between metacarpal 1, for example, and proximal phalanx 1. And then in your feet, between the metatarsals and the proximal phalanx in your feet, and this is the metatarsophalangeal joints. So this is why, so we're talking about where your bottom or your proximal phalanx connects with your metacarpal. And because these joints are all condylar joints, this is why you can extend and flex your fingers, you can abduct and adduct your fingers, and you can move your fingers in a little circle, so you can also circumduct your fingers. So again, this is the bottommost joint where your knuckles are. The joints up here, remember, are hinge joints. So we're talking about the ones between the bottommost phalanx and your metacarpals. And the same on your foot, between your bottommost phalanx and your metatarsals. And another type of joint is called a saddle joint. You only have one of these. A saddle joint is unique that the two bones fit across each other kind of in the shape of a saddle. So you can imagine the kind of movement you would have if you were sitting in a saddle. So it allows for angular movement, including circumduction, but you cannot rotate at this joint either. So here's an image. So again, we can move in two directions. We can even do a little bit of circumduction. We just cannot rotate with this type of joint. So with a saddle joint, we can do flexion, extension, we can do abduction and adduction, we can do circumduction. And this joint is only in one place, and that is at the very, very bottom of your thumb, so the very base of your thumb where it connects to your wrist. And so this is also the joint that allows you to do the opposition and reposition, which is that unique motion that you can only do with your thumb. So again, saddle joint is only in one place, and that is between metacarpal 1 and your carpal bones, specifically the trapezium. So this is called the first carpometacarpal joint. And just to be clear, you only have one saddle joint. Well, you have two, one in each hand. But you have it's at the bottom of the metacarpal 1. So between the metacarpal 1 and the carpals. That is your saddle joint. That is the joint that allows you to do opposition and reposition. And then the last type of joint is a ball and socket joint. So as it suggests, these are shaped like a ball fit into a socket. This is going to allow multiple combinations of angular and rotational movements. So with the ball and socket joint, you're going to get flexion, extension, abduction, adduction, circumduction, and rotation. So you can, the last little image here, or the last little bit of animation will show you there's the rotation. So you can get rotation at this type of joint. So you only have two ball and socket joints. You have it at your shoulder joint, which is also known as your glenohumeral joint, and this is between your humerus and your scapula. And then your hip joint, between your hip bone and your femur. And if you remember from chapter 8, your femur has this nice round head on it that fits into the acetabulum on the hip bone. So two types of ball and socket joints, your hip and your shoulder. So quick little summary of the 6 types of synovial joints. So if we break them down by the types of movements, so only allowing very slight movements would be your plane or gliding joint. Then allowing only one type of movement, if it's just rotation, that would be your pivot joint. If it's just flexion and extension, that would be your hinge joint. If it allows multiple types of movement, so if you can do flexion, extension, adduction, adduction, and circumduction, that is a condylar or ellipsoid joint. If I add all these flexion, extension, adduction, adduction, circumduction, and I add opposition to it, I have a saddle joint. And if I, again, take all 3 of these, flexion, extension, adduction, abduction, circumduction, and I add rotation to it, that gives me a ball and socket joint. So that's a summary, another way to look at it based on the different types of movement. For the remaining parts of the chapter, we're going to look at some specific joints, but I am not going into as much detail as your textbook, so make sure that you only study the things that I point out and the things that are listed on your learning objectives. So we're going to start with the intervertebral joints. So intervertebral joints are joints between your vertebrae, and there are 2 types. So you do have synovial joints or diarthroses between your vertebrae, And these are between those articular processes. So if you go back to chapter 7, when we looked at the structure of a vertebrae, remember we talked about how they will have superior articular processes and facets to form a joint with the vertebrae above them, and they'll have inferior articular processes or facets to form a joint with the vertebrae below them. So you have all of your vertebrae stacked up, so you have a lot of these little synovial joints, and they are synovial joints. They are complete with the joint capsule and the joint cavity as we described earlier in this chapter. These are all gliding joints, which means very slight movements are allowed. However, even though there are small movements, you have a lot of vertebrae. Remember, you got 24 total vertebrae, and so they add together all of those different articulations being able to move very slightly, and this allows your spine to flex and extend. It also allows lateral flexion of your vertebral column, and it allows rotation, so you can twist at your waist, and that is rotation of your spinal column as well. So these synovial joints do allow a fairly large range of movement for your vertebral column. And then the other type of joint that you have in your vertebral column are symphyses. And remember, this is a type of amphiarthrosis, and these symphyses are where you have a pad of fibrocartilage between adjacent vertebral bodies, and we call these intervertebral discs. So if we take a closer look at the intervertebral discs, again, these are the pads of fibrocartilage between the vertebral bodies of the vertebral column. But while we're on this picture, you can also see here is an example of that superior articular facet that's going to form a synovial joint with the inferior articular facet of the one above it. But now we're going to focus on the intervertebral discs. So we are going to go over their structure. So the annulus fibrosus is this tough outer layer, and that's shown in the light purple here. And then you've got the nucleus pulposus, which is a soft, elastic, gelatinous core. This acts as a shock absorber, and also when your vertebral column does move, so when you do flex it or extend it or rotate it, these inner portions of the intervertebral disc can shift and help keep your spine in alignment and everything together as you move. And then you have these vertebral end plates, which is this dark purple line at the top and the bottom. So these cover the superior and the inferior surfaces of the discs, and these are made up of a mix of hyaline and fibrocartilage. But the entire thing is mostly made out of fibrocartilage, so that's why we tell you that the intervertebral discs are pads of fibrocartilage. So you can have some problems with your intervertebral discs. These tend to increase as you age, and the ligaments that hold everything in place become weaker and have gathered cumulative damage from all of the years that you've lived. So if you have your disc slip, or it actually will like shift to one side, and the annulus fibrosus, which is that tough outer part, basically becomes, it starts to bulge or it slips to the side. That's called a slipped or bulging disc. And if the nucleus pulposus actually breaks through the annulus fibrosus, that's called a herniated disc. So with a slipped bulging disc, you get a distortion of the annulus fibrosus, but the nucleus pulposus stays intact inside. And with a herniated disc, the nucleus pulposus actually breaks through. And the danger with both of these is that the shifted disc or the protrusions from the disc can press on your spinal nerves, and this can cause pain and numbness and sometimes even problems with movement depending on which spinal nerve is impacted and how tightly it is being compressed. In this section, we'll take a closer look at the shoulder joint. So the shoulder joint is also known as the glenohumeral joint. This is the joint in the body where you have the greatest range of motion, so it's your most mobile joint, but this also makes it the least stable joint in the body and the one that is most likely to be injured. So remember that mobility and stability in joints, or mobility and strength, are inversely related. So the more mobility you have at a joint, the weaker or less strong that joint is. So the shoulder joint is a ball and socket diarthrosis, and it is formed where the scapula has the glenoid cavity, forms the socket, and the head of the humerus forms the ball. And if you remember, the socket part, the glenoid cavity, is not that deep. It is rather shallow. That's one of the reasons that this joint actually has a lot of mobility, a lot of potential for movement, but it's also why it's one of the weakest joints, or the weakest joint. There are 5 major ligaments that do help to support and maintain the shoulder joint. I'm not going to test you on their different names, but you can see from this picture that a lot of them do attach to that coracoid process that you had to learn that came out the anterior side of the scapula. The glenoid labrum is a structure where on either side of the glenoid cavity, and this is a fibrocartilage extension that comes off of the scapula, and it helps to deepen the socket a little bit, because as we mentioned, that glenoid cavity is not very deep. It's actually rather shallow. So the glenoid labrum is a fibrocartilage extension that does help to try to deepen that socket a little bit and make it a little bit more stable. I do want you to know the difference between a shoulder separation and a shoulder dislocation. So a shoulder separation is the term that we use when you have a partial or complete dislocation of the acromioclavicular joint. So this is the joint between the clavicle and the scapula. Remember, the acromial end of the clavicle forms a joint with the acromion of the scapula. And if this joint is dislocated, either partially or completely, so from type 1 here, you can see there is a stretch in the ligaments. Type 2, those ligaments between the acromion and the clavicle are completely severed. Type 3, you have the ligaments between the acromion and clavicle are separated, and you've also separated some of the stabilizing ligaments that attach to the coracoid process. So multiple levels of shoulder separation. But remember that shoulder separation is between the clavicle and the scapula. What we call a shoulder dislocation is when you have separation between the humerus and the scapula. So if the head of the humerus comes out of the socket made by the glenoid cavity of the scapula, that is a shoulder dislocation. And because of the nature of the shoulder, this dislocation can happen in different directions. An anterior dislocation is when the head of the humerus slides forward out of the joint, and posterior dislocation is it slides posteriorly. Again, the joint becomes separated. So if we go back and look at the structure of the shoulder joint, there are also 4 major bursae in and around the shoulder joint. I'm not going to ask you for the names, but just know that the shoulder is a place where people who do a lot of overworking of their shoulder can get bursitis. Muscles play an important role for stabilizing the shoulder joint, and in fact, you should know that the rotator cuff is a term that we use to describe 4 major muscles and their tendons that reinforce the joint capsule. So you've got the supraspinatus muscle, the infraspinatus muscle, teres minor muscle, and the subscapularis muscle. So these 4 muscles and their tendons make up the rotator cuff, which again is helping to stabilize the shoulder joint. And in sports, you might frequently hear of people with rotator cuff injuries. Baseball pitchers and quarterbacks are at high risk for rotator cuff injuries because of the amount of force that they put behind throwing the balls, the baseballs and the footballs. So any type of overuse or extreme stress placed on the shoulder joint could result in a dislocation, but can also result in a rotator cuff injury. In this section, we will look at the elbow joint. So the elbow joint is a complex hinge joint that involves 3 bones. So remember that at the elbow, we have the humerus, the radius, and the ulna. So the largest and strongest connection of these bones at the elbow joint is the humero-ulnar joint, which is the joint between the humerus and the ulna. This is a hinge joint, and you have that unique trochlea of the humerus that looks like a spool-shaped end to the humerus. and you've got the trochlear notch of the ulna, which is that C-shaped area of the ulna that wraps around it. So these two bones tightly interlock and form this hinge. The shape of the trochlear notch limits the plane of movement so that you can only have flexion and extension. There is no other way these two bones can move together. And the olecranon, which is the process on the back of the ulna, when you extend the elbow, the olecranon, if you remember, folds up into the olecranon fossa on the back of the humerus, and that limits the degree of extension. And that's why you cannot hyperextend, or you should not be able to hyperextend your elbow. You also have a humeroradial joint, which is going to be where the radial head forms a joint with the capitulum of the humerus. And then your textbook doesn't really consider this part of the elbow joint, but I do. So you also have the proximal radio-ulnar joint, and that is where the head of the radius fits into the radial notch of the ulna. And this is that pivot joint that allows supination and pronation of your forearm. So the elbow joint is a very stable joint for three reasons. First, the bony surfaces of the humerus and the ulna interlock. So again, you have that C-shaped trochlear notch that fits around the trochlea of the humerus, and that is a really tight interlocking between those two bones. Secondly, you've got a single thick joint capsule that surrounds multiple joints. So the joint capsule is shown in magenta or pink in this image. So you can see that a single capsule, which is that tough fibrous outer covering, surrounds all of the joints. So it surrounds the joint between the humerus and the ulna, between the humerus and the radius, and even between the proximal ends of the radius and the ulna. So having just one capsule will also lend a lot of stability to this joint. And you also have some very strong ligaments that wrap around and reinforce the joint capsule. So we're not going to go over the names of all of the different ligaments, but as you can see from this image from your textbook, there are quite a few ligaments wrapping around the bones at the elbow. So the elbow is also not very mobile. It is only a hinge joint. You can only have flexion and extension. And then if you do want to include the proximal radio-ulnar joint, you can also have that pivot motion where you do supination and pronation. But other than that, not a lot of mobility at the elbow joint. And remember, as mobility decreases, stability increases. So all of these things allow for the elbow joint to be stable, but you don't get that much different movement at that joint. Even though it is a very stable joint, it can be damaged by severe impacts or unusual stresses. So if you have a fall and you land on your arm while it is partially flexed, you can dislocate your elbow. Depending on how you fall, can dislocate either the humerus from the radius, or you can dislocate also the ulna from the radius, but you can also dislocate the humeral ulnar joint as well. And if the epiphyseal growth has not yet finished, so we're talking about childhood, right, while you still have that cartilage there and your bone is still growing longer, you are at more risk for what's called a nursemaid's elbow, which is a partial dislocation of the radial head. This is caused by an upward twisting pull on the arm. And the reason it's called nursemaid's elbow is because this is frequently done by adult caregivers who are taking care of young children, and they might be in a rush and they're kind of pulling the children along behind them, grabbing them by the arm and tugging. And by doing that, if they tug in just the right way, they can pop that radial head right out of the joint. So in this section, we're going to look at the hip joint. So the hip joint is a sturdy ball and socket diarthrosis or synovial joint, and the hip joint is actually very stable. So it has a lot of movement like the shoulder joint, but it has a lot more stability than the shoulder joint. So the reasons that this joint is very stable is first you've got the head of the femur, which is a ball-like structure, and you've got the acetabulum on the hip bone where that head fits into. And the acetabulum is much more of like a socket that the head can slide into than the glenoid cavity at the shoulder joint. The acetabular labrum is very similar to what we saw in the shoulder joint, and that you've got an extension of fibrocartilage that increases the depth of the socket. And this is really going to help out at the hip joint because you already had a socket to start with, so adding this fibrocartilage to extend it just makes a deeper socket. You also have a very dense, strong joint capsule that surrounds the hip joint. You have 4 very broad ligaments that wrap around this hip joint. 2 are shown on the anterior view. There are 2 more on the posterior view that I'm not showing here, and I'm not going to ask you to remember the names of these ligaments. And then you have a lot of muscles in and around your hip and upper thigh, and all of these muscles surround and pad this joint. And again, the muscles can help hold those bones together and prevent the femur head from coming out of the socket. So altogether, the hip joint is a very stable joint. The hip joint is also not aligned with the weight distribution along the shaft of the femur. So if we take a look, the stress that is put on by your body weight, it comes down at an angle through this hip joint. So the way that the stress is actually passed through this joint means that there is not a lot of force that wants to knock this joint out of socket. And in fact, you are more likely to have a fracture in the femur than to actually have a dislocation of the hip joint itself. And the 2 common sites for fractures in the femur are the femoral neck and between the greater and lesser trochanters. So the bottom line is your hip is a very stable joint, and you are more likely to, quote, break your hip than to actually dislocate that joint. And what we call a broken hip or a hip fracture is actually a break in the femur. So I know it's a little bit misleading, but because it's right very close to the hip joint, people call it a hip fracture, although it's actually a break in the femur. And as mentioned before, there are 2 common types of hip fractures. One is a femoral neck fracture, where you actually have a break between the head of the femur and the rest of the femur. And the other one is an intertrochanteric fracture, where you have a break that runs between the greater trochanter and the lesser trochanter. And the last joint we'll look at is the knee joint. So the knee joint functions as a hinge joint, but it is the most complicated hinge joint in the body, so it's much more complicated than the elbow or the ankle between the tibia and the talus, or the hinge joints between your phalanges. The knee joint actually has 3 different articulations. So you've got the medial condyle of the femur that is articulating with the medial condyle of the tibia. The lateral condyle of the femur is forming a separate articulation with the lateral condyle of the tibia. And then you've got the patella, which is moving backwards and forwards along the patella surface of the femur. The joint capsule of the knee is also thin compared to where we've seen in other places, and it's even incomplete in some areas. However, the knee joint is strengthened by a lot of ligaments, tendons, and muscles that surround it. So a complete dislocation of the knee joint is rare, but there can be a lot of damage to component parts of the knee, as we'll see in a moment. So the knee joint has these 2 fibrocartilage pads called menisci. So meniscus is singular and menisci is plural. So you have a medial meniscus between the medial condyle of the femur and the medial condyle of the tibia, and a lateral meniscus between the lateral condyle of the femur and the lateral condyle of the tibia. So these are 2 fibrocartilage pads. They act as cushions. So as your knee joint moves and you've got these 2 different articulating surfaces, they help to cushion the stresses placed on those surfaces, and they also help to conform to the shape of the articulating surfaces. So since the 2 condyles on these 2 bones are pretty much just flat areas, the menisci sort of feel as like packaging material to help fill in the area and make those connections stronger and conform better. They also provide some lateral stability to the joint. As we'll see in a moment too, they also help when you extend and lock your knees. There are also prominent fat pads and many bursae that help to reduce friction in and around the knee joint, especially because of the patella, and the patellar surface is kind of, bone that's sticking in that actual tendon. So you want to have some extra protection against friction. So the knee joint has 7 supporting ligaments. Again, I'm not going to make you learn all of the different ligaments, but there are 2 you should know because these are the 2 that are commonly injured in various knee injuries, and that is the anterior cruciate ligament, which is abbreviated the ACL, and the posterior cruciate ligament, or the PCL. So these ligaments actually cross over each other at the posterior side of the knee, and that is what cruciate means in Latin. So cruciate means cross, so that can kind of help you remember that you've got the anterior cruciate ligament. You can see part of it here. It's better view from the front, and then you can see the posterior cruciate ligament. So they're crossing over to help connect the femur to the tibia. So at full extension, so when your knee is straight, like in the anatomical position, and we say the knee is locked, the ACL actually becomes tightened, and the lateral meniscus is wedged firmly between the tibia and femur. And this allows you to stand up for long periods without using the muscles that actually extend your knee. And so this way you can stand without using a lot of extra energy to contract those muscles. You do have to contract muscles to unlock the knee if you want to flex it. So injuries can occur in multiple areas of the knee. Like I said before, you don't usually get a full dislocation of the knee, but there are a lot of areas that are subject to stresses and injury. For example, the menisci can be torn, so you might have heard of someone that had a torn meniscus. Popping sounds in the knee are frequently caused by the menisci popping in and out of position. This is because of wear and tear, and they are no longer held in the correct position. Ligaments in the knee can also be torn, so you've got those 7 strong ligaments, but they can be damaged. The most common one that you usually hear about is the ACL, or the anterior cruciate ligament. Tears can happen to this ligament when your knee is twisted while it's extended and you're bearing weight on it. And this is a very common sports injury. The patella can also be dislocated or shattered. And if you remember from previous lessons, cartilage, which is what the meniscus is made out of, and ligaments, which don't get a very good blood supply, neither of these heal very well. So neither your menisci or your ligaments heal well. So if you do damage these parts of your knee, they can lead to the development of chronic problems, because even with time and rest, you're not going to get the knee come back to it like it used to be when it was healthy and young. And eventually, if you've got enough cumulative damage to certain areas of your knee, you may require surgery to repair ligaments or even replace the whole knee joint. So knee replacement surgeries are actually fairly common, and that's because these areas of the knee do not heal well. A short little section on aging and arthritis. So all forms of arthritis are caused by damage to the articular cartilages in your joints. Remember, the articular cartilage is that hyaline cartilage that covers the ends of your bone. So once that cartilage is degraded and has broken down, the ends of your bone can then contact each other, which causes friction and pain. There are many different types of arthritis, but we are going to focus on 3 that are more well known than the others. The first one is the most common, and this is osteoarthritis. This is the cumulative wear and tear that comes with age. So as you use your joints throughout your life, some people use their joints, subject them to a lot more stresses than others. You can get cumulative damage to that cartilage. Remember, cartilage does not heal well. It is avascular. And so over time and your lifespan, you do build up damage to the joints. This is also known as degenerative joint disease, or DJD. And again, this is damage that happens or accumulates over time. Another type is rheumatoid arthritis. In this type of arthritis, your immune system actually attacks the cartilage in your joints. And so this is a type of autoimmune disorder, and this is not going to be as common as osteoarthritis. You should also note that the term rheumatism is a general term that people use to describe pain and stiffness that affects any part of the musculoskeletal system, which includes bones, muscles, and joints. So do not confuse rheumatism with rheumatoid arthritis. And another type of arthritis is gouty arthritis. In this type of arthritis, you get uric acid crystals that form within the synovial fluid, which can cause pain when the joint is moved. And this is a type of arthritis that is seen in a condition called gout. And with gout, you usually only have the joint at the base of your big toe affected, which is your first metatarsal phalangeal joint. So immobilization of a joint can also cause degeneration. So if you remember from earlier in this chapter, the synovial fluid circulates in and out of those articular cartilages like sponges every time you move and use a joint. So if you injure a joint and you hold it immobile, that is actually bad for it. The cartilage begins to break down because it's no longer getting nutrients from the synovial fluid. So we don't want people to have complete immobility at their joints, even after a joint injury. And so there's a term called continuous passive motion, or CPM, that refers to the movement of an injured joint to encourage the repair process. And this is usually done by physical therapists. And there's also various types of machines that can help with this as well. If a joint is past repair and it can't heal on its own, there are complete joint replacement surgeries for the big joints like the hip, knee, elbow, and shoulder. And this last section is just a summary. So there are some tables provided in this chapter of your textbook that contain all of the information that we've covered previously, not only in this chapter, but in the previous 2 chapters. So there shouldn't be anything new in these tables, but they will help you organize the material, and they're a great resource for looking back. So for example, these are the axial skeleton joints. We talked about how the cranial bones and facial bones are joined by sutures. You can also have a synostosis, and these are types of synarthroses, or joints with no movement. The maxilla has a joint with the teeth, and the mandible has a joint with the teeth. And if you remember, these are a type of synarthrosis called a gomphosis. And again, no movement. And then there is a joint between the temporal bone and the mandible. That's your temporomandibular joint. That's actually a combined plane joint and hinge joint. And that allows you to elevate and depress your jaw. You can do the retraction and protraction, and also some lateral gliding. If we look at the vertebral column, if you remember the joint between the atlas and the occipital bone, that is actually a condylar joint that allows you to flex and extend your head. So if you nod your head up and down like you're saying yes, that is the joint between the occipital bone and atlas. We also talked about the joint between the atlas and the axis, or the atlantoaxial joint. This is that pivot that allows you to rotate your head like left to right like you're saying no. Then we talked about the other vertebral elements and how you've got a symphysis, which is that pad of fibrocartilage between your vertebral bodies. And then you've got a diarthrosis, or a synovial joint, that's a type of a plane or gliding joint between the articular processes of your vertebrae. We didn't much talk about the joints between the lumbar vertebrae and the sacrum. We did talk about the sacrum to the hip bone. That's the connection between the pelvic girdle and the axial skeleton. That's that sacroiliac joint. That's a plane diarthrosis, allows slight movement. We didn't really talk about the sacrum to coccyx, or the coccygeal bones, so you don't have to really pay attention to those. And then if we look at the thoracic cage, or the ribs, remember, if you connect the bodies of the vertebrae to the heads of the ribs, that's a plane type joint. We call those the costovertebral or vertebral costal joints. You also have joints between the transverse processes and the ribs, same thing. Then where you have the ribs connect to cartilage, that's a synchondrosis. So again, that's a joint that doesn't move. But we talked about those different types of synarthroses at the very beginning of the chapter. And if we look at the appendicular skeleton joints, we've talked about all of these in one way or another throughout this lecture. So again, you can come back and refer to this table. It can remind you of the movements allowed at each joint. the type of synovial joint you would find, and what the actual joint name is. So these are the pectoral girdle and upper limb joints here, and these are the pelvic girdle and lower limb joints here. And again, this is a great resource. There should be nothing new in these. We've covered these all in one place or another, but it will help you review and look up information quickly. And that is the end of Chapter 9. And that is all of the information that will be covered on your second exam. So exam 2 will be chapters 6, 7, 8, and 9. So 4 chapters on exam 2.